She's a 37-year-old female, mother of 2 children, presented with a long history of mild effort intolerance, class 2. Few episodes of efforts in copy. The last one was 2 months prior to the presentation. When she went for sterilization surgery after the second childbirth, alive child, she was denied surgery because of desaturation detected by the obstetrician. She went and consulted few cardiologists, and a diagnosis of an EMF was made, and she was on diuretics, digoxin, etc. Physical examination revealed dusky nail beds with peripheral oxygen saturation of 90% in all 4 limbs. Clubbing was there, small volume pulse, a prominent A wave in the jugular venous pulse. Heart sounds were normal, no murmur. Electrocardiogram revealed low voltage complexes, non-specific T wave changes, and biatrial enlargement. This is the echo done in my place. Long axis view, the left atrium was looking a little bigger. Short axis view, the right ventricular outflow was dilated, and it stands in contrast to normal or smaller size pulmonary artery. If you look at the third one, the short axis at the level of mitral valve, the right ventricle looked little bald, like the trabeculations were not very prominent. And the another cut at the short axis view revealed an oscillating atrial septum with atrial septal defect, fossa ovalis type, but little low placed one. This is the apical 4-chamber view. On your right, color flow demonstrates predominant left to right shunt across large sized ASD. If you look at the right atrium, significant enlargement, but right ventricle looked truncated. It was very difficult to say whether the right ventricle was looking smaller or something is obliterating the right ventricular apex. But the clue was in the apex of the left ventricle. If it were endomyocardial fibrosis, left ventricle would not have had this sort of inverted flask-shaped configuration. Actually, the left ventricular apex was coming and binding the right ventricular apex. This raised a doubt, and this is the zoomed view of the apical 4-chamber view. Tricuspid annulus was smaller. There was no tricuspid regurgitation. Transesophageal echo, normal left ventricle, atrial septal defect was documented, and right ventricle again looked smaller in size. Atrial septal defect with bidirectional shunt across the defect. A saline contrast study revealed both right to left as well as left to right, and you can see the negative contrast also. She was refusing to go through MRI, so we had actually asked for CT evaluation of her heart and vessels. It revealed right atrial enlargement. There was reflux of contrast from right atrium into the vena cava. Right ventricle was reported to be hypoplastic. Central pulmonary arteries were smaller, but the intrapulmonary arterial branches were normal. Another additional finding was bronchial arteries were dilated, and there were systemic pulmonary artery collaterals. Two from left subclavian artery supplying both hilar, and one from celiac artery supplying the right lower lobe. Finally, she was convinced to go through cardiac MRI. Big atria, predominantly right atrium is looking very big. The right ventricle was smaller. Now, if you look at the right ventricular apex, there were few trabeculations. So this, cardiac MRI, confidently rules out other causes of small right ventricle like endomyocardial fibrosis. Main pulmonary artery was smaller, but the flow characteristics did not reveal any obstruction. Left atrium, left ventricle, mitral valve was normal. The frozen pictures of cardiac MRI. Look at the right ventricular dimension. It is longitudinal dimension. It's only 50% of the left ventricle. Tricuspid valve attachment was normal. And this finding deserves attention. Left ventricular apex was winding around the right ventricular apex, which is supposed to be the imaging feature of this condition, isolated right ventricular hypoplasia. ASD with bidirectional shunt was also documented. She underwent cardiac catheterization. Left heart pressures were normal. Right atrial pressure was elevated, 14 millimeter of mercury. And this dominant A wave was transmitted to the right ventricle as well as to the pulmonary artery. Pressures, RA atrial pressure, A wave 14 millimeter. There was a desaturation in the left atrial level, and there was a small step up of oxygen at right atrium. So, bidirectional shunt at atrial level, mild gradient between main pulmonary artery and branch pulmonary arteries. Coronary angiography revealed another important finding. A branch from the circumflex artery was, feeding the right lung, a part of right lung entering into the hilum and disappearing. Right ventricular angio in the lateral view, the shape, looked like that of the fist of boxer, and left ventricle was looking normal. Pulmonary angiogram, pulmonary arteries are smaller, but intrapulmonary branches are normal. The subclavian injection revealed the anomalous arteries from subclavian artery supplying both the hilum. Actually, the right ventricle is tripartite both in anatomy as well as in embryology. The inflow is derived from the bulbus cordis. Outflow is derived from the common trunk, and the trabeculated portion originating from the outpouching of the bulbus cordis. So, this condition known as isolated right ventricular hypoplasia is considered to be due to defective development of trabecular component of the right ventricle. Generally, RV hypoplasia is secondary to diseases like tricuspid atresia, pulmonary atresia, or Epstein's anomaly. Isolated RV hypoplasia is supposed to be a rare event, particularly in an adult. 2022, this year, a systematic meta-analysis of reported cases. There are only 49 cases reported so far. This isolated RV hypoplasia generally is associated with either PFO or ASD permitting bidirectional shunt. Whenever there is desaturation in a patient with the ASD with no pulmonary stenosis or pulmonary hypertension, look carefully the right ventricle, because right ventricular hypoplasia may be the reason. Recognition and complete evaluation is important because it helps you to decide about the management. If it is gross hypoplasia, you may have to go for Fontan. Mild to moderate, you can accept a glen, bidirectional glen. At times in the right ventricle was reasonably good, you can go ahead and close the atrial septal defect, maybe with a fenestrated device. Thank you.